been designed to actually help everyone to learn and grow and actually take this part of activity to the next level. The idea is that whatever whosoever is wanting to start this activity in their respective centers, they should be able to do it after following these kind of webinars. And I have tried and attempted my best to ensure that we do a seminar which is giving you enough information regarding how the flow cytometric cross match works and how we should be setting it up in our own centers. And as I told you, I genuinely encourage all of you to ensure that you guys are giving us questions which in case you have any challenges which you need to be answering. So I think without further ado, I would request Dr. Shubho to start the recorded presentation, which I've already passed on. And I'll be available all the time for all the questions or anything that comes in between. You can just put it in the question answer
Yeah,
session.
chat box is there.
We can, yeah, in the chat box. And I'll be trying to reply whatever needs to be replied quickly on the chat box itself. But if there is something which needs further elaboration, we will discuss it online as well. So, hoping that it will be a good academic activity for everyone. Thank you. Dr. Shubho, can we just start with the
Yes.
presentation?
Can you start the recording, please?
Yeah, good to go, sir.
All right, thank you. So, greetings from BLK Max Super Specialty Hospital, New Delhi. The task assigned to me today is to talk about importance and limitations of flow cytometric cross match. I bring you warm regards from the Institute of Laboratory Medicine, BLK Max Super Specialty Hospital, New Delhi. And this is my lovely team back home, which enables me to get the data, which I'm able to share with most of the people, on not only on flow, but other things as well. Now, how I have designed my talk today is I have defined my talk in the following subheadings. The first one is the DSA, standing for Donor Specific Antibody Assays. We'll give a brief introduction about flow cytometry per se as to how the entire technique pans out. We'll talk about flow cytometric cross-match methodology and its interpretation, its pros and cons. And we'll also talk about some new assays which can be done potentially on flow cytometry, including endothelial cell cross-match, as well as the flow PRA and the cytotoxicity cross-match and C4D assays. So what do we mean by DSA? DSA stands for Donor Specific Antibody. And this is a thing that is the most fearful for majority of my clinical colleagues. Most of my nephrologists would not want to be in a state like this on seeing a kidney which they have transplanted into a person turning blue and black. And obviously, when you look at the surgical pathology, anatomic pathology part of it, you are able to see these classical changes of a pre-existing donor-specific antibody causing a hyperacute rejection. So this is primarily due to a pre-existing donor-specific antibody, which you're seeing in this particular case. And more important than that, you're not only restricting yourself to identifying a donor-specific antibody before the transplant, you're also worried that post-transplant, there can be presence of certain antibodies which can be de novo, and these antibodies potentially can also lead to what is called a graft loss. So even in such conditions, you want to identify the presence of a de novo donor-specific antibody in the early stages post-transplant so that you're able to institute appropriate therapy and salvage the graft as much as one can. What is important to realize is that majority of these, patients, who have de novo donor specific antibodies, their survival is obviously impaired because obviously in such conditions, the donor specific antibodies give you the antibody mediated rejections, which eventually lead to graft loss at some point of time. So donor specific antibody obviously becomes the point of contention or something which we are really concerned about and wanting to identify. And there are many assays or tests which can potentially be done for this. And the ones which are most commonly used across are, for example, the CDC or the complement dependent cytotoxicity cross-match, the flow cytometric cross-match. And of course, we all know that a lot of us would like to do what is called the solid phase assays. And these solid phase assays include the the panel reactive antibody assay, the Luminex cross-match, and the single antigen bead-based assay. These are beyond the purview of my talk. However, we'll be giving some references to that in certain slides. Now, when you go ahead with the transplant, what is your primary aim? The primary aim during the transplant, pre-transplant testing is you take your donor, you take the recipient, you take their serum and you take the cells from the donor, assuming that the cells that you're transplanting is equivalent to the organ that's being transplanted, and these cells and serum, you make them react with each other, which is what is called a cross-match. And if there are presence of any antibodies, you're able to pick them up and warn the physician beforehand of the potential possibilities which can be due to the presence of HLA antibodies. On a post-transplant state also, there is a similar concept. You're looking for the presence of HLA antibodies post-transplant and warning the physician of potential complexities which can come up because of that. Now, this is how you would generally look at the various assays which would come up for assessment of sensitization. They could either be cell-based or they could be solid phase assays. The cell-based assays hitherto were either the CDC cross-match with all its other modifications which have been done so far, and of course the flow cytometry-based cellular cross-match. You would also like to do what is called the solid phase assays using the Luminex platform, and this would also give you the possibility of identifying or picking up the sensitization in a patient. If you look at all of these assays today, what assay is the best assay to do? I would summarize it by quoting this particular article in front of you, which says nothing is perfect in the art of defining HLA-specific antibodies. So for all practical purposes, if you have availability of the entire repertoire of testing that you can, without any fear of the money which gets involved along with it, then you should do all the assays, and subsequent to getting the values or the interpretations, the results from these assays, you can sit down and interpret and define as to what we'll be dealing with respect to a particular patient. Nevertheless, all these antibody detection methods have a specific sensitivity and specificity. The moment you move towards the solid phase assays, especially the ones which are having single antigen bead assays, you're looking at a much higher sensitivity. And as far as the specificity part of it is concerned, obviously the specificity also is relatively much higher initially as far as the cell-based cross-matches are concerned. Now, what is flow cytometry? We're just changing a little gears to identify, to first of all understand what is flow cytometry. Flow cytometry is comprised of three words: cyto meaning the cells, metry meaning the measurement, and flow meaning that the cells are flowing in a stream. So obviously they need to be live cells, and these cells need to be flowing in a stream. And once you are making them flow in a stream, you are able to identify either their physical properties, their chemical properties, or biological properties. And you also use certain antibodies to identify their immunological properties, which gives you an identification of what you are dealing with. All right, so a classical flow cytometer has three important parts. One is called the fluidics, the other one is called optics, and the third one is called electronics. And this is a classical picture which majority of the people will show in their presentations when they deal with flow cytometry. What's obvious here, you have a flow cell and you have a laser source, which is the source providing the light, that is the laser light. And these are the cells which are passing through the flow cell. And as the laser light falls on these cells, the light either gets scattered in the front, which is what is called the forward scatter, which gives you the size of the cell or the particle that interferes. And whatever falls at the 90 degrees is called the side scatter, and this side scatter gives you the internal complexity of the cells. Now, if you would notice, you're having these pictorial representation of what is called a photomultiplier tube, and all different photomultiplier tubes which are able to pick up different wavelengths of light. And as you can see, there are various wavelengths of light: the yellow, the blue, the green, and the red in between, which are having these lenses which make them fall in a certain specific manner. And there is also something called mirrors which obstructs the passage of some of the light and directs it differently through various photomultiplier tubes, ensuring that these PMTs are able to pick up specific light that we are interested in. So by using this photomultiplier tubes and an array of filters and mirrors, we are able to direct the light passing to a certain area. There is also a concept of what is called hydrodynamic focusing. The hydrodynamic focusing means that when we are trying to run the cells through a laser light, obviously the cells will have a tendency to overlap with one another. But by using what is called hydrodynamic focusing, using sheath fluid from outside in the central core of cells, we're able to make them fall in a single straight line, just as the way we are seeing this particular slide. So the laser beam obviously strikes the cells. When it strikes the cells, the shadow which is created in the front will give you the size of the cell, and whatever is falling at the right angle, that's 90 degrees, gives you the complexity or the granularity, as I told you already. In addition to all that, I did mention that you can have antigens which are present on the cell surface. As you see in this particular case, these are various antigens which are present. And if I want to identify these antigens, I can take this antibody, the yellow Y-shaped antibody which I've shown here, which has got these different stars on it. This is nothing but fluorochromes which are tagged to the antibody. And once I strike these fluorochromes with a laser light, the fluorochrome gets excited and it moves to the next higher orbit. Obviously, it's an excitement, but the excitement obviously will not remain for long. This excitement will come down to the basal level. And when it comes down to the basal level, it will emit a different wavelength. And this wavelength will now be picked up by those mirrors and, directed by those mirrors, as well as by the lenses to a certain photomultiplier tubes, wherein it will be then recognized. Now, where all can I pick up these antigens? I can pick up the antigens on the membrane of the cell, within the cytoplasm, in the cell organelles, even within the nucleus. So potentially, any of these areas within a cell or outside on the cell membrane can be taken into account, and we can identify various, different cell antigens which are present on the cell. Now, when we do this activity, we need to remember we are also interested in making sure that all the cells are actually live. We can't have dead cells in our picture. So when we talk about live cells, we are also therefore wanting to know and make sure that if there are dead cells, they do not come into our picture, because the moment the dead cells come into the picture, they will bind these antibodies, which I showed you in the previous slide, non-specifically, and give you a non-specific reaction. So for example, if you see these two pictures over here, you have these dead cells, which have, taken up the kappa as well as the lambda staining. Whereas when you are taking only the viable cells, the cells have taken only a lambda staining, obviously telling you that they are actually clonal cells, but the live ones are actually clonal cells, but the dead cells have taken up non-specific binding. This is the same thing which has been used in flow cytometric cross-match also for doing what is called a flow cytometry-based cytotoxicity cross-match, and I'll come to that a little later. Now, various things which we need to keep in mind on flow cytometry, we will have the plots, which will be the plots in front of us, and majority of the times we use a histogram for the histogram and the dot plots for our flow cytometric cross-match. We create a software-based gate around it, and I'll show you that in my subsequent slide. That displays the statistics, and eventually we analyze the statistics to get the values what we were interested in as far as the patient values are concerned. So just to show you this picture, you have these singlets over here, then you have the forward scatter versus the side scatter, giving you the lymphocytes, monocytes, and granule. It's a classical peripheral blood sample which has been run across. This is what I meant by histogram, and if the histogram is showing you a peak which is much towards the right hand side, gives you a positivity here. If the same histogram was on the left, that means it was negative. And of course, these populations which you're seeing over here can potentially also give you similar values. Now, what we are looking at is the moment we put up these software kind of rounded or rhomboid things around these cells, this is what we mean by gating. And once we have gated, we are able to identify subsequent populations or subsequent analysis of this by gating those cells. So let's look at a classical flow cytometric cross-match. In a classical flow cytometric cross-match, you're basically taking all your mononuclear cells, and in those mononuclear cells, you're subsequently identifying them as either B cells or T cells by using corresponding antibodies. For identifying T cells, you use a CD3. For identifying B cells, you use either a CD22. We have now started using CD15 for a very long time, 19 for a very long time. And of course, you can also use many other B cell antibodies, but you need to be very specific in terms of B cell antibodies that you use. Now, when you do flow cytometry in transplant immunology, what are we doing? Are we trying to detect an antigen, or are we trying to do an antibody screen? In fact, what we are trying to do is we are trying to identify what is called an antigen-antibody interaction by checking it out on a flow cytometry-based stuff. What is the purpose of our cross-match? The purpose of our cross-match is to ascertain the presence or absence of a donor-specific antibody. And by way of identifying these antibodies, we are actually trying to pre-warn the nephrologist or the neurosurgeon of the potential risk for hyperacute rejection or a humoral rejection, which can come later on. So for all practical purposes, we're not really looking at something being complete contraindication. Now, what is the assay goal? Whenever you set up a test, what is your goal? Your assay goal is to clearly identify the presence of an anti-HLA antibody or any other antibody which potentially can interfere in your assay. You also want to determine preferably the titer of the antibody, which potentially can be difficult, especially when you do it on flow cytometry. And you will also like to identify whether it's a specific antibody or a non-specific antibody. Now, what is the importance of a flow cytometric cross-match? Why do you really want to do a flow cross-match at all? When you have a CDC cross-match already, there is no point doing a flow cross-match is what most of the people would have asked. But the answer to that is when you do a CDC cross-match, even when you use an AHG enhanced cross-match, it has a relatively low sensitivity, and majority of the times it's unable to detect low level of antibodies. And I'll show you that in our multi-assay which we had done in one of our cases. The flow cross-match is also a more sensitive and a quantifiable method for donor-specific antibody assay. And I'll show you that in my subsequent slides where I'll demonstrate to you from a study which we had done in multiple centers. And most importantly, out of all of the things which are there with respect to the CDC cross-match, it will reduce your subjectivity if you do flow, and there will be much lesser inter-observer variability when you do a CDC cross-match. What is the procedure for doing a flow cross-match? Well, for all practical purposes, you need to have donor cells because that is what you're trying to emulate a kidney from a potential transplant for a potential transplant recipient. You also need to have a serum from the transplant recipient to make it react with each other. Obviously, you need to add an anti-human immunoglobulin to identify the antibody which potentially may be in the serum. And you also need to identify antibodies, use antibodies which will detect the T's and the B cells individually. So this is something which you need to do. So if you look at the flow cytometric cross-match procedure, it's pretty simple what all you need. You need a donor sample, and the donor sample, which is most important, is the mononuclear cells, preferably only lymphocytes, which you isolate from the peripheral blood. You can also you also need to take a serum sample, which has to be taken from the recipient. So basically, cells from the donor, serum from the recipient. But for any test, when you do a test, you need to make sure that there is a negative control and a positive control, because that will determine whether your assay went off well or not. And mind you, the viability of the cells that you're using should be preferably more than 80%. Can you use anything else other than the cells coming from peripheral blood? Yes, in a cadaveric transplant, a lot of people prefer to use a lymph node or spleen because that helps you to get the cells in a much higher concentration. We are also preferring, a lot of people also prefer to take mononuclear cells from the serum sample from the patient, from the donor, but that has minimal significance. What is more important is the mononuclear cells from the patient itself to do what is called an autocross match. There is a lot of controversy to this now. A lot of people believe that this may not be really necessary. Coming to the positive and the negative control, you need to have a pooled normal human sera, which is from non-sensitized individuals. That's a preferable thing. And you can also use a sera from a male blood group AB donor and must not be cytotoxic. There are commercial ones also available, but what we realize is when you use commercial negative control, it may not mimic the exact procedure in the same way because majority of the times the sera has been kind of lyophilized and it's not having the same matrix as to start with. Now coming to the positive control, one uses dilution, which we have to be very clear about. The positive cutoff, we need to be very clear how we define our cutoffs, and that's also something one would need to keep in mind. So what do? You prefer to do the entire process on on a flow wash wafer, which is preferably ice cold. Mind you, you also prefer to use what is called an anti-human immunoglobulin, but only the FAB fragment and not the FC part of the antibody. The reason is when you use the FC part of it, there are many FC receptors which are available on monocytes and other cells, mononuclear cells in the peripheral blood. And you may have non-specific binding of this anti-human immunoglobulin, giving you a positive cross-match. And you should also preferably use CD19. We don't use 20 because in today's day and age, a lot of people are using anti-CD20 antibody during the conditioning of some of the patients. Now, as far as pronase is concerned, most of the people do not prefer to use pronase because they believe that the pronase is not going to give them any benefit overall. But remember, use of pronase actually helps you to ensure that there is minimal non-specific background staining because it cleaves all the FC receptors from the cell surface, most of the FC receptors. And it also can be used in cases post-rituximab therapy because in such case, CD20 will also be cleaved by pronase. But just remember, the pronase concentration used for CD20 cleavage is much higher than the usual pronase which is used by majority of centers. So obviously, as I told you, you will have your donor cells, you will have the recipient serum, and once you take these material, so serum from the recipient, and as I told you previously, you also take cells from the recipient to set up an autocross match, and from donor, you are primarily taking cells. Sometimes you also want to keep a serum to check out if there is any positive reaction between the donor and the cells on its own, and the cross match for that as well. Okay, and now what do? How do you decide your cells? So basically you have what is called density braced cell isolation from the donor. You use a phycol material, which is a density gradient, and you centrifuge the sample with a phycol. The moment you centrifuge it, you are able to isolate your lymphocytes. The problem in this is that you're not only isolating lymphocytes, you're isolating other cells as well, other mononuclear cells as well. And in some cases, even the neutrophils come into the picture. Of course, these cells need to be used as quickly as we can. Otherwise, you will have to protect them by using DMSO and storing them at -20 at least. Of course, the serum can also be extracted, which needs to be extracted from the recipient. And once you've taken the serum, you mix them up. Now, when we use a density gradient method, there are some issues which we need to keep in our mind. It's a relatively longer procedure. We have RBC lysis, which is required before you put up on the phycol. And of course, you need additional steps if one wants to have pure lymphocytes for assessment. Now, majority of the people will tell you one major technical concern, and that is that if you have a very low level of anti-HLA antibody or any antibody which was present in the patient's serum, recipient serum, the problem is that if you have these antibodies which are against, say, class 1, they are also expressed by other cells. For example, you have monocytes, macrophages, and if you've not been able to get material appropriately, even neutrophils. So the antigen to antibody ratio will be altered, and this will lead to a false negative flow cytometric cross-match. In addition, you will have lesser number of B cell events, and this generally happens in patients from deceased donor transplants. So therefore, the preferable thing is that you get pure lymphocytes. And to get pure lymphocytes, you will have to use what is called immunomagnetic lymphocyte isolation. There are many ways to use it. EasyCep is the one which comes from Stem Cell Technologies. And in this case, there is a kit which is available wherein you can use what is called human leukocyte isolation kit. It does it by using what is called the negative selection of the cells. And you're picking up all the cells in this case, the lymphocytes, which will include the T cells and the B cells, and sometimes even the NK cells. What's the mechanism? Well, you have a target cell, you make it react with an antibody, the one which you want to remove, and that antibody eventually will go and bind to the magnetic sphere. And then either you can use an automated separating system in which there are magnets inside, or you can use a manual magnetic system, and all the red cells, everything else gets removed completely. And once you remove it, so what do? You basically have a tube in which you have all the cells. You add this solution to it, which is basically a cocktail, antibody cocktail. It will go and bind to all those material, all those cells which are not to be kept in the assay which you need. Once you incubate it, after that you put it in a magnetic, in a what should I say, a stand which has magnet in it, which is for the manual one. And once you put it there, all the ones which are connected to the magnet will get removed. And when you decant the rest of it or pour off the desired fraction, that will have isolated cells. And this entire process takes just about 20 minutes. So this is a preferable methodology of doing lymphocyte isolation. And it also helps you to make sure that your assay becomes more robust. Lot of assays, a lot of people have done this work previously. I'm showing you some work which was done in the US, wherein they looked at the cell yield and the duration of the assay time, and of course the accuracy. So what happens is, while both density gradient and lymphocyte preparation by EasySep gives you the cells at a higher concentration, you get pure lymphocytes by using lymphocyte separation using EasySep, and it happens in a much lesser time. That's less than 25 minutes. Yes, the cost per test becomes slightly higher, which is where the trade-off is. Now, if you look at lymphocyte, immunomagnetic lymphocyte isolation, and this is the data which has been shared by Dr. Rob Lewinsky from Canada, wherein if you use this particular methodology of Ficol hypake, when you use a density gradient, you are able to isolate your T and B cells for sure, but there is a lot of junk which comes along, and that can potentially bite the antibody, which is like at a low level may not give you a positive reaction. And therefore, even the median channel shift will not be as great as the whole blood versus the lymphocytes only. Compared to this, when you have only lymphocytes, you're able to identify lymphocytes alone, and you're obviously able to get much higher concentration of lymphocytes, which eventually gives you a better separation as well. Sorry. Now, more importantly, this gives you a much better isolation when you're using a density gradient versus the immunomagnetic separation in cadaveric transplants. This is a sample from a cadaveric transplant. Just look at the lymphocytes, the viable lymphocytes they were able to get, just about 1.2%. Compared to the same sample being run on a immunomagnetic separation, you're able to get about 77% lymphocytes. And obviously, with that kind of a concentration of lymphocytes, you're able to get much better separation and a much better analysis of the flow cross match itself. Now, how does a classical flow cytometric cross match, irrespective of whichever way the lymphocytes have been extracted? You isolate the lymphocyte, you identify the lymphocyte as a T or a B cell by putting up a CD3 or a CD19. If there is a pre-existing anti-HLA antibody or an antibody which reacts with antigen present on these lymphocytes, it will go and bind to that lymphocyte. For example, in this case, it's bound to the T cells, and then you add an anti-IgG antibody, and this anti-IgG antibody, the FAB fragment alone, will go and bind to this antibody which has been tagged to the lymphocyte on a T cell. And once you strike it with a laser, it fluoresces and gives you a fluorescence which is recorded. Similarly, if you take a B cell, identify it using CD19, and if there is again an antibody, anti-lymphocyte antibody, which can react with B cells, it will go and bind to it. And then obviously an anti-IgG will go and bind to this particular antibody, and on the laser part of it, it will fluoresce and give you that reaction. So you've been able to identify an pre-existing this white antibody which is there in a patient, identifying it clearly whether it reacts with a T cell or a B cell, and that's what gives you a T cell or a B cell cross match. We can also do the same thing for an IgM. It's in a similar way. Instead of using an anti-IgG, you're using an anti-IgM, and obviously the rest of the assay remains the same. And in this case also, you're able to identify an IgM. We happen to do both IG and IgM in our center. Now, this is the usual assay setup which has been given across by the Bray et al. Way back in 2004. And if you notice, there are 4 tubes. You have a negative or an autologous serum. And mind you, in all of these cases, you're using only IgG, right? So you have a negative or autologous serum 1, you have a negative or an autologous serum 2, you have a pooled positive serum, and of course the patient sample. Again, some people prefer to use a replicate one instead of just 1 tube. People also prefer to use 2, and you can also reset up tubes for each additional serum in case you want to set it up for more than 1 donors. In our center, we are using the similar kind of a thing. Of course, we have the unstained one just to check out the non-specific binding of antibody at the background. Then we do a auto cross match, the negative control, the positive control, and of course the patient sample. We also do the same thing for our IgM as well. So we have the IgG and we also have the IgM. Now, remember, when you set up the flow cytometric cross match assay, you are expected to calibrate your instrument appropriately. When I talk about flow cytometry, as I told you, it's about photomultiplier tubes, it's about laser power, and it's also about the mirrors and the lenses taking care of everything correctly. In addition to that, as I told you previously, there is fluid which is involved and pressure which is involved across the fluid that needs to make sure that everything is standardized appropriately. So therefore, when you have set up the calibration appropriately, which can be done on a good flow cytometer on a regular basis, you have to analyze a minimum of 5,000 to 15,000 gated lymphocytes. And by convention, in most of the manuals that you read about flow cytometric cross-match, they'll tell you try to get at least 1,000 T lymphocytes and 1,000 B lymphocytes. Mind you, when you try to do this on a 5-call high-bake, it is not easy to get it done. Whereas when you do the same thing on a flow cytometer, on a lymphocyte easy separation method by using immunomagnetic separation, you're able to get this kind of an assay. Now, what do? You, as I told you, you run the assay, and once you run the assay, you get your respective flow histograms, and you look at what is called the median channel shift, and the entire activity either happens on a 256 scale, which is the scale on the flow cytometer plots, or a 1024 scale, and then you subtract the value from the negative control from the patient's serum value. And in today's day and age, it's preferable to use a ratio because many a times conversion of linear to logarithmic scales at potential problems which can be added to your laboratory working. But what is most important is to set up the cutoff values for a positive cross match. Now, this is what has been given across in ASHI standards, the American Society of Histocompatibility and Immunogenetic Standards. It's given for T cells and for the B cells. They've given on a TC 256 scale, 10 to 15 is your cutoff. For the B cells, 25 to 30. And again, for 1024, 40 to 60 and 100 to 120. And what is important, what most people prefer to follow nowadays is the ratio of more than 1 or more than 1.2. How do you interpret a flow cross match? If both are negative, the T and the B cell reaction, that means there is no antibody present. If it's positive on both, that means there is definitely a class 1 antibody, but it could also be a class 2. When you have a negative T cell and a positive B cell reaction, you need to really worry, is it class 2 or not? Or sometimes you might need to repeat the assay. And if you have a T cell positive and a B cell negative reaction, a low titer class 1 antibody or a non-HLA antibody needs to be kept in mind. Now, how does it look like when you're doing a flow cross match, especially on a assay which is coming from MNCs that you've taken across on a 5-call high-pake? So this is how it will look like. You will have a forward side scatter and you've gotten on your cells. There is some contamination of granulocytes here. And these mononuclear cells, you do it on a mononuclear cell gate. You identify your B and T cells as you are seeing in this particular case. And then once you identify your T and B cells, you look at the presence of, the anti-IgG on both the T and the B cells. As you see, in both of these cases, these peaks are actually in the first, log, and therefore clearly negative. Now let's see what happens in case you have a positive sera. In case you have a positive sera, just see what has happened here. There has been a complete shift from the left side to the right side in both of these cases, and you're able to this shift from the median of the first peak which we had here to the median of the peak here gives you what is called the median channel shift, and that's what everybody needs to keep in mind. The similar concept is there for the B cells, but what I would like you to notice is for the B cells, the reactivity patterns on the histograms give you a very broad kind of a peak, and this is very difficult to differentiate whether it's positive or negative. For example, if I show you the positive case in this case, for a B cell to differentiate, whereas on T cells, you're still able to identify. However, on B cells, it becomes difficult to differentiate between the two. Some data from our center and some positive and negative cases. I'll not get into details of this, but just to tell you what's new in a flow cross match. In a flow cross match today, we have what is called an improved flow cross match, which is otherwise called a functional assay, wherein you do cytotoxicity assay, and I'll show you that in subsequent slides. There's also called a flow cytometric cross match, wherein you're trying to detect non-HLA antibodies. You're looking at presence of avoiding interference by therapeutic antibodies, and there are some assays using pronase, flow PRA, and of course the C4D. Now, a lot of people have been of the opinion that since CDC does a complement fixation and we are able to know whether it's a cytotoxic assay or not, can we do an on-flow cytometry? The answer to that is yes. You are adding a rabbit complement to the same assay that you were doing previously, and then you get what is called the rabbit complement fixing flow cytometric cytotoxicity assay. We tried our hands on this in some of our cases, and it's a reasonably easy test to do. And the only thing is you are going to add what is called a viability dive. So that's what has happened in this case, and you are able to get your details subsequently. So this is a labeled antibody which you are tagged across along with it, and you are then using a 7-AED. And if the cells become dead, which they should become after adding the complement, this 7-AED will obviously be taken up by the cells and you will be able to pick it up on a flow cytometric assay. As far as the improvements and limitations of the flow cytometric cross-match is concerned, we need to remember you need not give a false negative result. So remember, we have to be very clear as to how long did the sample take to reach you. Are the cells actually kind of viable or not? That's again something which we need to keep in mind. We need to make sure that there is no false positive on B cells, and therefore pronase treatment in every case is what everybody has nowadays started adopting. We have adopted it as well. And of course, rituximab interference and looking at the functional part of the assay is also equally important. And detection of antibody binding by endothelial cells also becomes equally important in some cases. So, looking at what is called endothelial cross-match by flow cytometry, there is an assay called XM1. A lot of people do use it internationally. India, it's not been so popular. However, what we do is we take the cells and we are able to identify these and gated endothelial cells again by using a negative selection using EasySep. And then once we have taken these cells, we make it react with the serum just as the way we did previously, and we identify whether it's IgG or IgM. We have tried our hands on some of the cases sometime in the past, and it's been reasonably good. Then as far as in the monoclonal antibody era, what do? We use pronase. Once we use the pronase, it's able to cleave the bonds between the CD20 and we're able to get the values across. Now, we know that Luminex per se, we're talking about solid phase assay, and a lot of people would prefer to do a solid phase assay for flow cytometry. But can flow cytometry per se do solid phase assay without using the Luminex part of it? Yes, we can do that by using what is called a microparticle screening assay. And in this, we use what is called a flow PRA. Again, in PRA, we are not really looking at a specific antigen, but we are basically trying to inform the surgeon of a likelihood transplant antibody, which potentially can give us a problem. Now, all of these are various conditions where we can potentially do it. And what do? We basically have beads, which are microparticle beads. We can do either a screening assay for IgG or we can do a specific assay for IgG. And depending upon the class, the antibodies that we have been, labeled on these beads, we are able to get hold of positive or the negative panels. These are the various beads which can be used. You have the class 1 and the class 2 beads. And depending upon their reactivity with the serum, we are getting various, kind of patterns that we get from it. For example, in this case, this is a negative control. We have these beads which we have taken up, the bead class 2 beads. And in this bead, the antigen reactivity is negative. But when we take the same thing on a class 1, for example, and class 2 here in a control positive serum, we're able to identify the reaction compared to the previous one. So that gives us, again, there is a median challenge shift which we calculate and value. And again, here is another one where we have a very classical one and a small tiny class 2. So we can pick up the microparticle based assays on this case as well. Coming to C4D flow PRA based assay, in this case, it's a relatively uncommon test. Of course, more commonly, C4D is done on renal biopsies, but it also helps you to detect high levels of antibodies if they're present. So in this particular case, for example, if you see the presence of an antibody, which is a C4D positive antibody, we've done quite a number of cases. I'll not get into details of this because this is a relatively older data. But we realize that, we are able to get reactions with respect to Luminex, SAB, the SAB or the flow MFIs, which are kind of meaningful and give you almost similar results. Now, what we have done in the recent past, this is in the year 21-22, what we did was we did a multi-center study across 3 major centers in Delhi, which was us, the Apollo and Medanta. And we looked at, various assays which we did. For example, we did the cell-based assays and in combinations also, and then looked at their relative sensitivities and specificities. What we realized is when we do a CDC cross-match alone, what is obvious is that we have a very, very low sensitivity. It's just about 12.5%, less than 12%. And when we do, however, the specificity of this assay, the moment we got it positive, then it was surely a 100% specific assay. In all such cases, we were able to get a SAB positivity as well. However, when we had a combination of this flow with the CDC cross-match, obviously the sensitivity went up much higher to almost 84%. We also tried to look at the HLA bead-based assays, which is otherwise called the HLA assay on the single antigen, not a single antigen assay, but a screening assay. So in this case, the moment HLA class 1 and class 2 were used, obviously the sensitivities went much higher. to the tune of almost 97% when both of them were used together, so along with the flow cytometry. So when we used a combination of CDC crossmatch with flow cytometric crossmatch and HAS, look at the sensitivities, the way it became better. The moment we had flow cytometry and the bead-based assay on a Luminex, the sensitivity was nearly 100%. And obviously, there was a little bit of a trade-off on specificity, which was eventually picked up on SAB assays. So this is where we have there are lots of studies which have been done in the past, and we have also done a similar study here in our center across 3 centers, and this is where we figured out that when you do an assay which is comprising of flow cytometric crossmatch and a Luminex based screening assay, we are able to give much better assays. This is just to show you some data of discordant and concordant cases. In most of the HAS beads, we had a challenge of DQ or DP not getting represented, and therefore flow getting positive and HAS becoming negative. And also some discordance with respect to the cases wherein we had the presence of the HAS or the flow cytometric crossmatch not correlating very well. I'll recommend all of you to go through this article, which is published in Transplant Immunology as of 2021. And we also had some false negative cases of flow cytometric crossmatch, wherein we realized that there could be some degree of, prozone phenomena which has happened. So what do we propose in the Delhi approaches? We propose, instead of doing a CDC, we just do a flow cross match and the antibody screening assay. If both are negative, it's low risk and there is no further testing which is required, and we can proceed for the transplant. However, if either or both of them are positive, we ask for the high resolution typing. We also look for the presence of donor specific antibodies using SAB. And then if there are no donor specific antibodies, we proceed for transplant. But if we find a DSA, we ask for a paired exchange or a deceased donor transplant. So to summarize and to take home, flow cytometric crossmatch, immunoglobulin, IgG, flow PR, and C4D are extremely useful assays that should be used by transplant centers who have an access to flow cytometry. And for all practical purposes, flow cytometric crossmatch has been proven very significantly that it's a better assay compared to the classical CDC crossmatch, and in many ways, no way inferior to the Luminex-based assays. However, I'll end with this one article at the end again, that nothing is perfect. If you have the possibility of doing all the assays, please do all the assays and then only sit down and interpret as to what you should be doing in further case. This is important to realize because every case is a new challenge, and a multimodality approach is the best way to define it. Remember, it's the man behind the machine who matters the most, and therefore a thorough knowledge of flow cytometry standardization and interpretation is mandatory before one goes ahead with a flow cytometric crossmatch. Thank you very much for your kind attention. Once again, acknowledgements to my lovely team back home, and should there be any questions, I'll be happy to answer.
Thank you, sir, for all this, for a lucid presentation and a detailed explanation of the technical things. So there were a few questions which have already been answered in the question and answer session and in the chat box also. So I would request all the attendees to please post their questions in the question answer session in the chat box. So while you do that, I'll just ask a few questions from my side. So now, sir, you have explained that the flow cytometry has a high sensitivity while there is a trade-off and there is a little bit of low sensitivity, low specificity. So in this situation, how would you want to interpret a CDC negative flow positive situation? Would it be prudent to negate a transplant? Say no, that we cannot do a transplant. Can you
On the
elaborate on
flow.
that? Yeah, on
Yeah.
the flow.
So I think if we look at it, there are two possibilities which can potentially happen. One, we have a CDC positive and flow negative. This is a bit too unusual. This is not what we expect to happen because CDC is supposedly a relatively less sensitive test, whereas flow is a relatively more sensitive test. So flow should pick up in most of the cases. Why does this happen that we sometimes get a flow negative test, whereas a CDC was positive? This happens when either the antibody to cell concentration was just too high, for example, the prozone phenomena, or else you might not have taken the appropriate lymphocytes for your assay. So, for example, if we have taken all the cells on FICOL, the low level titer of antibody may sometimes not give you a good reaction on flow cytometry. Now, that's about CDC positive and flow negative. But let's say the other way around, where we had a CDC negative, it was pretty clean, both T and B cells independently, no challenges at all. But when you did a flow, you got a cross match which was positive. Either it was positive for T cells or it was positive for both T as well as B cells. So in any of these cases, now it has identified an antibody. The problem with flow cytometry is it's a non-specific way of picking up antibodies. It may not be a relevant antibody to the transplant. It may be an irrelevant antibody, which could be anything, any other antibody which may not be specific in that particular patient. So when we ask for an assay, we always prefer that let's go ahead and do a what is called HLA antibody screening assay, which is more like a PRA kind of an assay, wherein you have beads on a Luminex platform, which are all together, like screening beads. And then when you do an assay on that and that comes clean negative, you still can go ahead with the transplant despite having a flow positive cross match. Having said this, what is extremely important to remember is the beads which are manufactured by our companies today, they may not have representation of the antigens or the alleles that we have in our population. So when you are assessing your, reports which are coming in from your laboratories, please make sure that they have given you a very clear, identification of the fact that indeed all the antigens were represented in these beads, and then only the entire activity had been done. So that's extremely important.
We have taken all the cells on Python, the local level title of antibody is not as one.
There is a question from Dr. Rakesh. Yeah, there is a question from Dr. Rakesh Chauhan. So some centers are not doing CDC. So should CDC and flow cytometry be done for a better outcome? Should there be a combination, or can we go ahead with just one of them?
So if we go by conventional guidelines which have already been published in world literature, and that's been published in the journal which is now called HLA, previously used to be called tissue antigens, and even in our routine practice and the article which I have quoted in my presentation today, what we realized is if we do only one assay, it may not be sufficient. So the guidelines also suggest the same, and we also prefer to do the same. You should at least do one cell-based assay and one solid phase assay if it's possible for you. You can use a flow cytometer for doing a solid phase assay as well, but you should do two assays minimum to define whether you're going to go ahead with a transplant or not. Or you may want to desensitize the patient subsequent to that. But doing only one single assay, for example, only flow cytometry, you may be actually depending too much on one single test. And as I told you, flow cytometry does not come without its own fallacies. It has its own challenges. It has its own false positives. It has its own false negatives. So a combination testing is what is preferred. As I mentioned in our article also, the details that we have done in our centers, 3 centers across Delhi, realized that we should ideally be doing an assay which should cover cells, which should also cover our a solid phase bead, where we should have the entire ability of our antigens. So as long as we are doing that, it should be good enough.
Okay, so what about standardization of the flow cytometer and its assay? So how cutoffs are determined? Can you elaborate on that?
Yeah. So when we talk about flow cytometry based HLA cross match, the most important point that we need to define is how do we determine at what reaction do we call it positive? So that becomes an extremely important step, which is called determination of a cutoff. Now, for determination of cutoff, the important point is we need to have, first of all, the SAB based assay done. So you need to make sure that you have a single antigen based assay wherein you have a positive sera available to you. And with that positive sera, you will now try to see as to how much are you able to go down in dilution. So there is something called a dilutional experiment which can be potentially done. And in that, there are two ways to do it. One set of people prefer to do it as a single dilution each time. We prefer to do it as a serial dilution, just as the way we go ahead and do it for, like coagulation assays in our laboratories. And once you've reached a point where there is minimal signal to noise ratio between your negative control and that the last dilution, that gives you a cutoff of the median channel shift. So this is a very interesting thing which I can share with you as a standard operating procedure that we adopt, and is something which most of the people have adopted globally. There's also another point which you need to keep in mind. Sometimes people may not be able to get hold of single antigen bead, the assay part of it, or get the dilutional done, the serum done from there. So in such case, a lot of people have preferred to use clinical assay, like clinical follow-up. But obviously, with it has its own limitations. So therefore, just going for the clinical assay part, the clinical assessment part of it is not right. And follow-up using a single antigen bead-based positive sera in dilution should help you to decide your cutoffs.
So another question is from Dr. Rajkumar, and he's asking in cadaver transplantations, which is the preferable test? Is it CDC or is it flow? So
Okay,
would you determine that?
so I genuinely, CDC is a very difficult test to interpret in a cadaveric transplant. And the reason for that is in a usual cadaver, when we get it in our country, especially, we usually get cell death to the tune of maybe 10 to 15%, in cadavers, who have been dead for quite some time. So CDC, interpreting CDC in a cadaveric transplant can at times be extremely difficult. Now let's come to the flow cytometric crossmatch. The flow cytometric crossmatch, on the other hand, especially with the way I told you, if you're able to extract lymphocytes using a negative selection, you will have most of the times live cells which will cross more than 90%. So in such a case, when you do a flow crossmatch, it's highly reliable. The caveat is that when you're trying to do a flow cross match for that matter, or any antigen antibody reaction, ensuring that the cell to the cell ratios or the cell numbers are always kept constant. So when you're standardizing your assay, please make sure that you have defined your cell numbers and analyzed it with a positive control at serial dilutions, and you've been able to get a positive reaction in the correct manner.
Okay, there are some participants who have raised their hand. I'll just request them to please put the questions in the chat box. Another question: if in flow cross match positive case there is a particular donor antigen and that donor antigen is not represented in the single antigen bead kit, so how do we proceed for the transplant?
So
So
the point, so for all practical purposes, when you have a case wherein you had a flow cytometry positive assay and you got a single antigen bead assay done and you got a positive reaction, but you did not represent it in the SAB. The SAB did not have a
yeah,
bead at all, and then SAB turned out to be completely negative. Now don't
yes.
be under the impression that this is a SAB negative case and I can just go ahead with the transplant. It will have all its implications. Now the challenge is there are only two companies in the world at the moment, producing these kits. So you have an alternate possibility of going ahead and doing a SAB with say 1 lambda kit if you're using an Immucor kit. But how sure are you that that 1 lambda kit will also have that representation of the bead or not? So therefore, when you have a SAB which is not reliable and you have a flow positive cross match, I would definitely want the person to be desensitized before you go ahead with transplant.
Another question is how to set up a positive control. I think sir has elaborated that already. A quick word, sir.
Yeah, so positive control is pretty simple. You can buy a positive control from the vendors. The problem with the positive control when you buy from the vendors is that it's a lyophilized control and it does not mimic the sera in the right manner. And most of the times, in your set of the way you set it up, your dilutional experiment also may not give you consistent results. So therefore, while you may run a positive control to start with, you eventually should set up your own positive control by taking, pooled pooled sample from multiple the people who are extensively exposed to the antigens and are actually giving you positive reactions. So take that sera and then make a pooled sera out of that. And mind you, when you're setting it up, make sure that you check what is the lowest dilution at which it is still giving you a very good signal to noise ratio. In fact, it should be able to give you a good signal to noise ratio even at your lowest levels. So that's something which you need to keep in mind.
Okay. Another question is like, are the cutoffs for positive flow cytometry for T and B cells different, and why is it so? And what accounts for these differences?
Okay, so yeah, so if you go back and check out the my presentation when I was presenting, you would have noticed when you do a B cell cross match, B cell has got a higher density of FC receptor compared to the T cells, and non-specific binding on B cells happens to be a little more compared to the T cells. So when you have non-specific binding, you will have to actually negate that part of it as well. So when you set up your assay, you will notice that your values for your median channel shifts for B cells come out to be much higher compared to the medial channel shifts which you get for your T cells. So that's why that decides as to why you should have your cutoffs which are different for T and B cells. Having said that, it's also important to realize that sometimes the cutoffs may not be there may not be a huge difference, if I may say so. But still, ensuring that the cutoffs are defined for each cell line is extremely important. And another important point which you have mentioned in your question is also, do the labs routinely consider a prozone phenomena? Unfortunately, most of the labs which do flow cytometry, except barring a few, in the country which I'm aware of, they do not do what is called a dilutional flow cytometry assay, wherein you do upfront dilutions of say 1 in 2 or 1 in 4 or 1 in 10. There are a few labs in the country, 3 or 4 labs in the country, which are actually doing these dilutional experiments upfront. But if you're sending your CDC to the same lab, if you're sending flow to the same lab, and for example, if they would have gotten a CDC positive, it is imperative on the part of the laboratory to actually put up dilutions for flow as well. What we generally recommend nowadays is that when you're setting up your flow experiment, you need to at least put 2 additional tubes with every assay so that you are able to take care of the prozone which can potentially come in.
So there is another question from Dr. Vinayak. Like, is there any difference in the approach if flow B or flow T is positive? So I think that has been explained a bit in
Well,
the presentation.
I did mention that in my presentation as well, but having said that, we need to remember if you have a T cell positive, you're most likely dealing with something which is a class 1 antibody, or it may be even a non-specific antibody. But if you have a B cell positive cross match, whereas T cell was completely negative, sometimes it can be a non-specific binding of antibodies. So you need to redo your cross match also in such a circumstance. Or if it's like on a dilutional one, also if you're getting a higher titer, then it may not be really an effect of something which is non-specific. It may actually be an antibody which may be class 2, a low titer class 2. And sometimes it may be a mix of both anti-class 1 and class 2, though both the antibodies which could be present in such a case. So flow in per se, if I look at flow cross match, anything that comes positive, we should be actually investigating it further. It's important because this is a non-specific test.
So your comments about auto flow cross matches.
Fluorescence. Okay.
Yeah,
So I
autofluorescence.
think the thing is, see, by virtue of the fact that when we do flow cytometry, cells inherently have their own fluorescence as well. So there will be some degree of autofluorescence which will come into the picture. So this happens especially when you're not using, the pure lymphocytes. For example, if you're using a 5-call hypate to get your mononuclear cells into the picture, there is invariably contamination, as I told you, of macrophages. There is contamination of monocytes. There's contamination of neutrophils at times. All of them will actually form a part of what is called the autofluorescence. So that's why in my one of the slides where I had shown, how the assay design is created, you would notice the first tube is to set up your autofluorescence. So wherein you have put nothing, no cells, only the cells and nothing. And then in that, you're trying to see what is your background fluorescence which you're getting, and basis that you're deciding your negative controls and the subsequent reactions. What we have been doing for all these years is one thing which is something very important, that is, whenever you are setting up your negative control and the auto cross match, you must keep in mind that if you have an auto cross match which is showing you a higher fluorescence, then that will become your negative control rather than your actual negative control. So keep that in your mind, and as long as you follow that, it should give you a reasonably good sensitivity with respect to your assay on flow cytometry.
So any tip on how to control and how to store blood samples for cadaveric donors so that the cross match can be interpreted in a better way?
Okay, so what we've been trying for the last few months now with cadaveric donors is we have been trying to adopt a practice of collecting the samples. Usually, the moment they tell you, the moment they call you, just collect the samples and get them to the laboratory. And we have been using immediately trying to put it layer on a 5-call. Now we have started the practice of putting it on a negative selection also. I did show one of the slides where I showed you when I did a negative selection, the lymphocyte yield was much better, and the cells in that yield was also lesser. So what I would recommend is try to get the samples as quickly as you can. That's one very important stuff. And the moment you get the sample in your lab, because they are anyways fragile, cadaveric cells are always fragile, try to use and a methodology of negative selection by using immunomagnetic beat rather than a Ficol high peak. Ficol itself has a negative impact on the cells. It's relatively toxic to the cells. So therefore, if you use a negative selection using immunomagnetic separation of the cells, it will help you to get a much better cell yield, and that will eventually help you to do a much better assay, both for CDC as well as for flow cytometry.
So I think that brings us to the end of this session, and I'm very sure everybody has found it very useful. Since there are no further questions, let me just yeah. So I think we're there. So I'd like to express a lot of gratitude to Anil Handoo sir for taking your time out, doing such a detailed presentation, going to the nitty-gritties of the process and everything. I'm very sure the attendees would have found it very useful. And also we have covered a lot of clinical questions on how to interpret and like the exact applied things. So with that, I'll end this session with a warm thanks and warm regards to Anil Handoo sir and all the attendees for being here. And I'm very sure we'll be meeting for the next session, the third lecture in this series, and it will be on CDC cross match. So stay tuned. Thank you, sir. Thank you all the
Thank you.
attendees. Thank you.
Thank you, everybody.
Thank you. And thank you, the ISOT team, for having this